Don't worry, but my introduction is going to be in two phases. First, Peter S. Jensen. He did his undergraduate work at Brigham Young University and medical school at George Washington University, after which he went to the University of California at San Francisco for psychiatric training and child psychiatry training, and also at that time worked at the Letterman Army Medical Center. Then in 1989, he went to the Medical College of Georgia. Actually, it was earlier than that, I'm sorry. And that after that time, in about 1989-90, he went to NIMH, where he directed the Child and Adolescent Disorders Research Branch until 2007. Actually, 1997. And from 2000 to 2007, he was at Columbia University directing the Center for Advancement of Children's Mental Health until 2007. During that time, he established the REACH Institute, which he is president and CEO of at the present time. And this stands for Resource for Advancing Children's Health, REACH Institute. And you'll hear more about that, I'm sure. From 2009 to 2013, he was at the Mayo Clinic, where he was co-director of the Division of Child Psychiatry and vice chair for research. And then in his last move, he is now in Arkansas. Fairly recently, moved to Arkansas, 2 years ago? 2 years ago. Now, Peter's one of these guys who has achievements as long as your arm, so to speak. I will just mention three. He was the lead author and co-director of the multimodal treatment study in ADHD, one of the most comprehensive, wide, broad-reaching studies of attention deficit disorder ever done to that point. He received the Blanche F. Idelson Award for Research from the American Academy of Child and Adolescent Psychiatry, and the Regier Award for the best scientific paper. And that's just three things of the many, many things you've done in your now distinguished career. That allows me to move to phase two of the introduction. I'll be brief. In that I met this guy 30 years ago. Now, for all you younger people in the crowd, and you look at Peter and me, this will happen to you too, okay? It will. It just seems like yesterday, Peter, that we met. And at that time, I'd moved to the south, Augusta, Georgia. We joined forces. His enthusiasm and his family welcomed us. It was such a difficult move. And we started an amazing training program, joint training program between the Eisenhower Army Medical Center and Medical College of Georgia, which was and probably still is a collaborative for a well-functioning military academic arrangement. His enthusiasm, as you'll quickly see, was infectious, and he started all kinds of things in Georgia and then moved on to NIMH. And we learned so many things from your resident. I learned one thing from your resident. We're getting ready to discharge a patient. Is a patient ready for discharge? And your resident, remember Don Grogan? Don says, yep, locked and loaded. I said, locked and loaded? And that, of course, is military for having your weapons ready to go. And we had a lot of great time. One final thing. You have trouble remembering this, but 6 years ago, I chaired a symposium at the American Academy of Child Psychiatry entitled, When the Diagnosis is Bipolar, Are There Other Explanations? A number of us were very concerned about just the really nonsense, truthfully, about that diagnosis and how it was harming kids. But I had trouble negotiating that politically because there were forces, drug forces, other forces, drug company forces. And so I said, how do I put this together? And I wanted someone with stature, and I immediately thought of Peter. I said, if Peter's on the program, people are not going to be able to discredit it. And you probably don't even remember what you said, but it was a great program. And at the end of that time, we had a ballroom of 350 people clapping for the message, which was essentially broad-based mental health, not just drugs. Kids need more things to help them. And Peter was a huge part of that. Anyway, I could go on and on. It's great to have you here. And your topic is, because I did have a job Jan gave me to do, to kick off the pharmacology symposium, which sounds like an exciting morning looking at the program, Overlooked and Underserved, Addressing Youth Mental Health Needs in Pediatric Primary Care. Welcome, Peter.
You can just put it down. Thank you, Alan. As Alan pointed out, we go back a long ways. Actually, Louisville and I go back even further. Of course, I should say Louisville. I was here in 1972 at Fort Knox. And And I remember first time I'd ever really come to the South, and so I was in ROTC at that time, and I remember carrying a pack up this hill, and there were two hills that the drill sergeants really liked to run us up and down. One hill was called Agony, and the other one was called Misery. And they said, "You're going to go down Agony and Misery." And so we go up and down Agony and Misery. And so I really learned how to perspire. I had never seen perspiration like that. So, but I had a lot of fun memories and got a chance to come into Louisville as well. My daughter's actually at the University of Kentucky in Lexington, so working on her master's and doctorate in psychology. So I'm delighted to be here. So I want to talk about children's mental health needs. Right now, if you look across the country, and if you look at all the child and adolescent psychiatrists and developmental behavioral pediatricians, you added this all up and say, all right, where are those people who are mental health-related medical specialists? In fact, you get about 6,500 full-time FTEs. People say there's about 7,500 child psychiatrists, but that's not quite correct. Some don't practice child psychiatry, some are academic only, or some are research. If you take 6,500 FTEs and say, this is what the nation's workforce is for addressing children's mental health needs, and they're going to work full-time on it, that's 40 hours a week, 50 weeks out of the year only. Let's only give them 2 weeks vacation. Each person would have 2,000 hours per year. Times 6,500 is 13 million hours per year for 14 million children. That's an hour per child per year if the job is to be done by specialists. It can't be done. And so unless we find a way to transform our services and embed mental health services, mainstreaming them into primary care, children will remain overlooked and underserved. And many primary care docs are surprised to find that nearly 50% of the job they actually have to do is now becoming mental health-related problems. ADHD, depression, obesity, anxiety, family issues that can often be very complex. And if great asthma care doesn't have to be done by a pulmonologist or an infectious disease specialist, but can be done in primary care, why not mental health? So that's really what I want to talk about today. The disclosures were presented, I guess, at the very beginning, but here's mine specifically. What I'd like to do is help you understand why we have this particular problem and talk about the role of primary care providers, could be nurse practitioners, PAs, physicians, etc., and give some examples of about the kinds of things that can now be done in primary care to provide good mental health services. And then talk a bit about the REACH Institute and what we're doing. And I'm looking forward this afternoon to further chat with leaders in the Department of Pediatrics as well as child psychiatry about potential ways that we could partner. Now, ADHD is an interesting example. One has to say, well, are these children overlooked and underserved? And it may well be the one area where there is probably some overdiagnosis, but despite the overdiagnosis, there's still also underdiagnosis. So if you look at children using epidemiologic studies who have ADHD, you find that there is some overdiagnosis, but more than half of those children with ADHD are not getting treatments in any current year. No actual active interventions. So we began to think about that. Well, how far does that apply to other problems? Well, according to the World Health Organization, if you think about the biggest problems related to disability and impairment, in terms of also projecting that forward over a lifetime, look at the number of things here that are related to lifetime disability. And I've underlined those that have significant behavioral components. Depression's actually the highest. ADHD is in there, but it's not in the top 10 list. If you look at the, now you can say, well, yeah, is that really a serious problem? Well, in fact, we're also talking about mortality, not just morbidity. So in many ways, this is, for us as a nation, a crisis, a mental health crisis. And so we know that while depression is the #1 leading cause of disability, many of these other same conditions also begin in childhood. In fact, most adult mental health problems begin before someone turns age 14. One would hope if we could intervene more effectively, we'd actually, in terms of adult outcomes, be doing much better and effective prevention. I'm all for prevention in the sense of, are there things we can do before someone even develops a mental health problem? Unfortunately, in our country, we still don't pay for prevention. It's a great idea, but you can't put something in systematically into a school system and find someone who will pay for it. And yes, there are things that could be done. But at this point from forward, we have no funding stream. Now, it may well change under healthcare reform, where we would become incentivized to say, look, I've got to save money. Here's a population that I'm responsible for. How do we get in and intervene before the problems become too significant? And so it's a great idea. Well, I hope that we can actually cross that threshold at some point. But even getting into those who now, that 8 to 10% of kids who have significant issues, that is also, if you will, in terms of adult outcomes, a very important road towards prevention. So how common are these problems? Excuse me, I'm getting a dry mouth. Reminds me of agony and misery. Happened there too. So this is from the U.S. Surgeon General, from some epidemiologic studies. And you can see that, yes, ADHD is there, but it's actually not the most common one. If you look at youth mental health problems, now if you added all these up, they're going to total well over 20%. And the reason that is because lots of children have multiple problems. And so it looks like around 30% or so. It's not that high when you consider comorbidity. Now, how do all these things happen? You know, what's going on? Is it something in the water? We're being tormented by bad genes? Is that the issue? Well, in fact, there's a number of things going on that we know are clearly linked to long-term disability and even early death. And look at this list. Now, we call these adverse childhood experiences. And a couple investigators from the CDC and Kaiser did a very important study, and they've been doing it with repeated publications and examination of the phenomena of about 70,000 adults, following them both backwards and forwards to look at, and actually how this happened. One of the investigators, Vince Folletti, was an endocrinologist, and he was struck in looking at adult diabetes and obesity, how often there seemed to be kind of adverse childhood experiences, sexual abuse, other kinds of things. And so, being at Kaiser, at some point he partnered with the CDC, and then they began to mine the giant Kaiser database, both retrospectively and then prospectively, and they found that, in fact, if you look carefully, these are the kinds of things that happen And these are the proportions for females and males, you can see. But look at the percentages. 28% physical abuse. Now, this is now essentially a normal population in the large Kaiser, all employed people who are in the Kaiser system. Okay, so we're not talking about the poorest of the poor necessarily. So we're talking about, generally speaking, a middle-class population across California principally. But look at the proportions. Now, what is the impact of those kinds of events? Well, that's what he was wondering about, because he thought, well, look at obesity. Well, turned out to be much more than that. So if you look at what we call these ACEs, or adverse childhood experiences, look at the medical disability and medical conditions on the left side. Ischemic heart disease, liver disease, COPD, substance use, also cancer has now been found as another one of the things, and essentially early death by at least a couple of years. Now, when you start getting 3 or 4 ACEs, in other words, if you go back and think of, well, what are the ACEs? You get 3 or 4 of these ACEs. What they found was 70 to 80% of those people will develop depression. Amazing. So it isn't like 2%, 5%, 10%, but 70 to 80%. So, and 4 ACEs on up gives you just a linear increase in the risk for all of these conditions. And of course, you'd expect the things on the right side, but the big surprise was this is linked to medical morbidity and mortality, not just psychiatric issues. Now, the World Health Organization does a lot to track illness and disability across populations by various ages across the world. And here in the U.S., what the WHO has found, if you look at lifetime disability projected forward for youth ages 0 to 14, you can see all the causes that we typically think about on the right. Cancer, notice how tiny that is, the one at the very top. Digestive diseases, endocrine, like diabetes, asthma, it's an important one. Congenital disabilities, CP, or various other congenital conditions from birth, including early developmental disorders. Compare all of those to the emotional, mental, behavioral ones. You can see it's the largest single category. Now, why are we doing such a poor job of really finding and identifying these issues? Very important question. How are we going to do better? Well, a few years ago, I worked with a team of some 20 investigators, and we thought, we've got to find a way to do better communication with the public. Because if everybody has to go read the DSM, say, well, what's a DSM condition? You got this long list of symptoms. That's not the way to communicate effectively. Isn't there a way to kind of streamline to say, look, this person needs to be evaluated. This person's at risk. Are there specific warning signs? And what we did was we mined 4 or 5 epidemiologic national and regional data sets to look at what we thought would be a key warning sign, that if you had that one thing, you better get in to see your doctor. And that would be an effective way of communicating to the general public, or to teachers, or even for the primary care provider to be able to say, oh, I've got one of these, I got to take this very seriously. Well, we looked at these warning signs, and I'm going to show you what they were, but we had about 13 of them. And so we constructed these warning signs so that it would be easily understood. One was severe depression lasting 2 weeks or more that affected a child at home or school. Another one was binging or purging to try to lose weight such that their health is now being affected. Another one was severe aggression that harms others. So basically, one sentence descriptors. And so we had 12 or 13 of those. And so here's an example of some of them. Here's your severe depression. We also said extremely hyperactive. So the child is at physical risk, like running out in front of cars. Not just garden variety ADHD, but severely hyperactive. It's affecting, put the child at risk or is causing school failure. So we crystallized the severity of those things in such a way that a single 5 or 6 word phrase would characterize it. So we went back to the epidemiologic data sets, and then we mapped onto disorders. And first of all, what we found was, of the kids that had, say, severe depression, 60% were seeing no one, and had seen no one for that in the last year. Extreme hyperactivity, close to 70%. Having made a suicide attempt, look at that. The parent knew about a suicide attempt. That was one of our warning signs. Well, why would a parent not bring their child in after they made a suicide attempt? Well, think about how a parent thinks. They don't think, oh, well, I don't care about my kid. No, they say, but his girlfriend broke up with him. Maybe that's the reason. So it was that, because they don't want to face maybe a very fearful, stigmatizing situation that the child might need a mental health intervention. Extreme aggression, look at that one. Disabling anxiety. And so look at, and every one of these, 50 to 90, 60, almost 60 to 90%, we're seeing no one, despite the fact that the parent and or the youth said, this is what's going on. Now, we also found, we mapped these back against their respective disorders. We found if you had one or more of these warning signs, you had an 80% likelihood to actually end up having a DSM diagnosis, but you didn't have to go through the entire DSM. So what we developed was a poster you could put in the primary care doctor's office. And it says, please tell your doctor if you have any one of these. And so we developed a lot of little media materials. And guess where this was published? It was 2011, along with a lovely toolkit in Pediatrics. The journal probably most of you know about, right? How many read this article? We're having trouble here. Okay. Agony and misery, that's what you need. Okay. So how do we grasp these issues and take them very seriously and say, we got to get up to speed to help these kids, because we're talking about long-term disability and even death. And this is where the primary care system, if we bring mental health into its forefront, we can make a huge difference in children's lives. Much more than seat belts, much more than bicycle helmets, much more than lead. This is the heart of disability, disease, and death. We have to be able to begin to confront these issues. So, how are we going to find those kids? Probably as many as 20% are they're either substantially at risk or certainly going to have multiple ACEs and are going to be those that are consuming eventually about 80% of our healthcare resources. So let's take a look at some of the more common conditions, and let's also examine some of the causes. So, as I mentioned earlier, we have a limited number of mental health specialists. As I said, would have just enough to give them about an hour a year. That's assuming no time for charting. And so we're talking probably a 3/4 of an hour per year per specialist. And never in my lifetime or your lifetime or your children's lifetime are there going to be enough child psychiatrists and developmental behavioral pediatricians. It won't happen. The pipeline is much too small. Now, if primary care providers didn't provide asthma care, we would have an incredible asthma crisis. We have lots of issues with asthma as it is, but it's mostly around training the workforce and increasing the quality of our interventions. It's not so much in we have an incredible shortage of people who could provide asthma care. Same principle applies here. How do we address these issues? And in this case, we're talking about provider shortages, and it won't happen through training more child psychiatrists. So I guess the second question is, all right, so if we assume there's provider shortages, why do people end up actually not getting mental health services? Well, shortages is one reason, but most people don't want to see a shrink. It's just very clear. If you actually, been national studies, if you look like, so this comes from national stigma studies, if a family is to go see a counselor, well, that's not so bad, counselor. If they're going to see a social worker, well, that's a little bit worse. A psychologist, oh my goodness, now we're getting serious. A psychiatrist, you think my kid is crazy? Okay, and actually, so that's the highest stigma level. It's very interesting. So, but what we know from what families tell us, they want, and the number of studies that have done this, they're very happy if their mental health care can be provided in primary care. Maybe you don't even have to call it mental health care. You can just call it the good, friendly doctor who knows what he or she is doing and who really cares about the family. In fact, if you look at families and you look at the longer-term outcomes and you say, here's an example from ADHD, what was the most important thing that helped you get your child successfully into adulthood? 80% of families say, it was the doctor that loved our family. Now, I don't know if anyone's ever going to say that about me. Not even my kids, you know. So primary care providers have an enormous advantage of knowing a child longitudinally over time, getting to know a family and understanding, and building a system of trust and as we say, a patient-centered medical home, ideally. You see also some of the reasons, most child psychiatrists, you go to any big city, they're mostly treating the out-of-pocket. They ask people to pay out-of-pocket. Essentially means the wealthy are going to get care, even with the child psychiatrists that are there in most of our big cities. So access is going to be an important issue that has to be confronted. Now, there's yet another reason, and you think about, let's just take depression. Well, depression, actually we know it shows up in primary care, but often we don't recognize it. It gets missed. Most of, in primary care training programs, both pediatrics and family medicine, there's actually very little support and training in the mental health area. And most people get a smattering of ADHD, but even there, it can be very difficult to get kind of the longitudinal support. We did a very interesting program at UNC Chapel Hill where we trained all of the pediatric residents using some of the methods we developed in the Reach Institute. But guess what? None of the faculty got trained, and then the residents didn't know where to turn. And so what we since have learned, got to train the continuity clinic, the folks who are on the ground. They're the role models. They're the supervisors. They're the ones that can really provide that day in, day out kind of support. And so we began looking at those issues of how we might actually transform pediatric training programs and family medicine training programs across the country so that they get the critical experiences, not just in ADHD, but depression and anxiety and oppositional defiant disorder and behavioral family problems, those kinds of issues. And so the other part of that problem is that even with the mental health providers we have out there, by and large, for example, if you say, hey, this child needs a state-of-the-art therapy, well, good luck. Most therapists aren't trained in our state-of-the-art therapies. And so there's about a 15 to 20-year gap between what we say, here's the latest research, everybody should be doing this, and before it actually penetrates practice. So there's huge issues with just making sure the workforce that's there is able and capable to address these issues. Now, the idea of healthcare reform is that somehow we have to address these three problems. And they're interlocking, as you can see. Access, outdated practices, provider shortages, and if you can actually bring a system together and hold that system responsible and accountable with kind of financial models and population responsibility, then we might be able to get some traction on these issues. And so that's the promise of healthcare reform and what we call accountable care organizations. Now, I don't know kind of if Norton, for example, is working on that. But what that means is, for example, if my population or a person within my population, a child, has mental health issues, I can't just carve it out and farm it out. I have to be able to provide that myself. Well, what if I don't have enough child psychiatrists? Whoa, how are we going to do that? What if we subcontract a child psychiatrist and now pay for a bunch of expensive services? Well, that ain't going to work. That's going to be, how do I do that? Well, that means we're going to have to think about addressing those issues and preparing our workforce. Now, people have tried a lot of different things, and sometimes people turn to CME. Well, unfortunately, the data shows CME doesn't work. This does not work. Just go home. This is not working. We know it doesn't change behavior. It changes your knowledge of a few facts, but it doesn't lead to transformations in clinical practices. And that's been shown again and again and again. So CME doesn't work, and oftentimes you get new healthcare managers saying, we got to do something. So maybe they'll spend a lot on IT with the new EHR, et cetera. And what we now know, that costs a lot of money, and it hasn't been shown to drive, certainly not to save money. And sometimes people say, let's hire a bunch of social workers to be therapists and care managers. And the underlying reasoning is thinking, well, the docs say, I don't want to do this. I don't do dental and I don't do mental. Okay? So the mental health, the healthcare leaders say, no worries. We'll give you a care manager. We're going to embed mental health therapists. That actually has untoward consequences, unintended consequences. Why? Because the docs go, don't have to really do it. And you go look at those systems where that's been done, and the huge issue is doctors never really got their toes in the water, or it's an extremely slow process. And in fact, in settings I've worked in, we've seen it's created actually additional resistance. If you don't first prepare the workforce and say, we got to do this. This is our kids. We got to do this. And then once we're up and going, then we're going to bring some additional resources in. It'll help you become even more effective. But if you don't capture the heads and hearts of the doctors and primary care providers, you'll end up spending more money with no difference in outcomes. Even things like pay for performance can backfire. Primary care docs, particularly pediatricians, in studies have shown are resentful if you start bribing them because they didn't come into it for the money. Otherwise, you'd all be plastic surgeons. You came in because you cared. You had different values. You cared about children and families. That's what motivated you. And you decided to take a pay cut at the very beginning because this was your dream, not playing golf on Wednesday afternoons, right? So a lot of these things have been tried, and they jump in and throw things at it, and the problem continues. So this whole issue of system redesign, well, that's true, but it's much more than just moving blocks and staff people around and organizing the flow of the system. We need to consider that think about leave no child behind. How about leave no doctor behind? All right. There's human factors. The system has to be inspired to change and to believe in what they're doing and where they're going and why it's important and to be involved in that. And those human factors, by and large, have been ignored. So let's talk about some of the ways that we might do better. I mentioned 3 and 4 with mental health issues are often missed in primary care. We know that Surgeon General, U.S. Preventative Services Task Force, and others are saying we're going to have to do better in primary care. We know that screening tools can increase rates of identification of mental health problems. And of course, I talked a bit about action signs, but there are valid tools out there that we can use. And so that's been well studied. Now, here are the action signs I talked about earlier. Just let you kind of scan the list. And actually, we vetted these in parent focus groups, in pediatrician focus groups, in teacher focus groups, in youth focus groups to make sure the language. I even vetted this with New York taxi drivers. I said, look, if the kid had this problem, what do you think you should do? Well, everybody said, oh, man, they should do something. So we're, again, trying to crystallize to get rid of the lack of clarity and to make it, and we didn't want to call them warning signs because that has a little stigma. He said, these are action signs. Get that kid in and of course, that, again, means the doctor's going to have to be prepared. So action signs or some of the evidence-based screening tools, all those would be appropriate steps that really need to be embedded in primary care. Well, once you got a kid, what are you going to do? Well, starting at that time when I was at NIH, we have now mounted dozens of multi-site clinical trials across the country.
Is there a button on those stickers other than that dial?
What works best for kids with depression? What works best for kids with anxiety? What works best for children with ADHD? What works best for children with aggression? What works best for children with autism? We now have dozens of studies, and pretty much, guess what? Every one of those studies, we had primary care in mind. So there was always, in those studies, testing optimal medicine, and we picked the medicine based on lots of double-blind, placebo-controlled studies of various medicines. We picked the optimal medicine versus the optimal therapy versus the combination. Now, how cool. Because that's what a parent needs to know. That's what
Dr. Noda
as healthcare providers, we need to know. What treatment should I do? And it's not, it doesn't come down to,
ADHD.
if you got 5 SSRIs, which SSRI? No, that's not what the data is. The data is much more, here are the SSRIs, here's the therapies, and this is what the SSRIs do, this is what the therapies do, and this is what the combination does.
Look at the slides.
And so it's a much more general level to say, what's the best practice? And in most of the studies, we also either compared treatment as usual, like community care, or placebo. And here's an example. The TAD study. We started this when I was at NIH. So we call this the treatment of adolescent depression. And so this is 432 kids with depression across the country. As you can see here, they all had high depression scores at the beginning. And then they were randomly assigned across 11 sites to either medication, in this case it's fluoxetine, Prozac. Now, drug companies sponsored none of these studies. These are all paid for by your taxpayer dollars and mine, because we know we needed credibility for this. Here's therapy, is the orange one here. Placebo is the kind of reddish-brown one, and then the combination is the blue one. And so we learned in this study is that medicine's important, but the combination's even better. Now, this doesn't mean that therapy didn't work. Placebo's pretty powerful. So we don't think therapy doesn't work, but placebo we've always known is pretty powerful. But in this case, we found that the very best outcomes with the lowest risk for later suicidal behavior was the combination treatment. Okay, so that's an example. We could use that in primary care because there won't be enough of the child psychiatrist around to see every kid. So at Arkansas Children's now, we've started this process by training all of our continuity clinic faculty. And then our next step is going to be to change the residency training program. But we want to make sure the faculty will first be ready so they can say, I know how to treat depression.
You and I are in the same boat, Ann.
One of our lead faculty yesterday on a call, we had about 10 docs from our faculty on the call, and one of them was now presenting a case. He said, well, I'm pretty confident with ADHD. I've just never done depression before. But now here, 8 or 10 other docs saying, yeah, you can do it. Yeah, I've tried it and this and that. And he wasn't quite sure about the rating scale he had used. And it's like, think about it. Learning how to do this, it's learning skills. If I gave a lecture on how to swim the butterfly, and I even had fancy videos, and I threw everyone in the pool, we'd have a lot of drownings. These are skills, and learning skills means you need coaches, mentors, and support over time. So here's a good example of where we really could be making a difference for many children out there with depression if our primary care providers are prepared. ADHD is another one. We talked about, yes, there is some overdiagnosis, but also there's still a substantial amount of underdiagnosis, or at least undertreatment. We know that a lot of times as docs, we shoot a little bit from the hip. Maybe we don't totally use the optimal criteria for making the diagnosis. And we actually know a lot that if you compare docs treating kids in the community versus very carefully managed and followed, careful use of the medicine, just like with diabetes, careful use of the medicine achieves twice as much effective resolution of symptoms. So you get about 25% of kids treated in the community, whether it be child psychiatrist or primary care, 25% show optimal improvement versus close to 60% when we use the medicine as effectively as possible. 60% versus 25%. Now, we kind of know that from other studies of asthma and diabetes as well. You've got to really nail it. But it also applies here as well. So there's yet another area that we could do. I mentioned a little bit about depression. So again, most of these kids are missed. So why does and we know most people think that they should be identifying it, and most want to screen for it. But in fact, the studies show in primary care we do it less than we do for other things. People are a little more reluctant it's like a little harder to talk about mental health. In this call yesterday, the pediatrician, who's a nationally known pediatrician, marvelous man, he was saying, well, if I say this to the parents, won't they get upset? He was a little worried about kind of the family pushback and stigma. And it took the other primary care providers on the call who have a little more experience. They said, no, in my experience, the families will embrace this. Generally, they embrace it. And so you shouldn't be afraid. And so that little anxiety would have held him back from doing that had he not had the support of his or her colleagues. So how do you recognize a depressed kid? Well, it's actually, think about what you need. Well, a rating scale might be good, but you also have to think about using your nonverbal skills. And if you're really good, you can tell the difference. If you're really well trained, it's very obvious which one is which, right? I have had 5 teenagers, so I know that this can be difficult. And so, yeah, it is hard. And so we're going to have to it is critical to get trained in some of these skills, but it's also critical to think about what are the evidence-based tools that will help us do this. So what's needed here? Well, we're going to have to find ways to expand our evidence-based training practices, both for practicing providers as well as providers who are currently beginning to, who are undergoing training. And that means technical assistance, quality technical assistance. We know from adult learning studies it's got to be hands-on coaching, sustained over time, with a mentor you trust and admire. And if that's not there, change of practices just doesn't happen. You need new information, and the kinds of tools. Now, I want to tell you a little bit about the REACH Institute. So we founded REACH in 2006, and Alan mentioned the resource for advancing children's health. Notice we didn't say mental health, very deliberately, because this is the key health problem in primary care, your single largest category. And so what were we trying to do? Well, think of that 20-year gap between what we know and what's actually done in practice. So we thought, we actually have to rapidly bring our workforce up to speed so that people are not applying 20-year-old practices, but state-of-the-art current practice and applying the latest evidence. So that really became our goal, a way to kind of increase workforce training, access, and quality and safety by providing the support needed to primary care providers so that they master skills. Skill mastery, not new knowledge. There are facts that are important for some skills, but never teach a fact that doesn't link to a skill. Because what we know is too many facts undermine learning. Too many facts prevent the learning of the key small set of facts that are needed for it, mastering a new behavior. So we started this back in 2006, and we've been doing this now. We've done about 75 or so trainings, and here's a sample of some recent ones. Over time, we learned, we've gotten better and better at this. So we've done about 70 trainings, 70 plus, about 2,500 providers, and it's actually a 6-month fellowship. So we have 3 days, hands-on, face-to-face, with 2 primary care teachers. Our primary care teachers are our most important faculty because primary care doc can't become a shrink. Now, we need a couple of shrinks there, too. You know, there are certain facts and kind of complicated questions, but they're role models or family physicians or nurse practitioners or pediatricians, sometimes developmental behavioral pediatricians who can say, come on in, the water's fine. Okay? And so there's usually 4 faculty. And after the first 3 days, then we put them on a series of conference calls. So it's like we've begun to teach them the butterfly, then we put them back home where they have their own little pool of patients, and they began practicing the strokes with their own patients and take turns presenting cases on the calls. And so what we've learned over time, now this, you know, here we're getting even perfect scores from the 30 or 40 docs we're training. They'll say, now this hardly ever happens. They'll say, incredible, outstanding. And so the overall quality and the impact, the first day of the training, people come in saying, ooh, I'm not sure what we're doing here because it's very hands-on, and we're bringing the participants up and having them practice interviewing. Well, if you start with faculty doing it first, of course, we have to show that we can do it, and we start bringing them up. And now if you have social phobia, could be a tough course. But we've only had about 4 people out of the 2,000 plus decide it ain't for me. And but we are grabbing some people at the end of the first day and saying, hang in there, hang in there. The end of the second day, the providers are going, this is really interesting. And we're capturing their hearts. By the end of the third day, they say, wow, this was amazing. Now, our best trainings are not done by our national faculty. Our best trainings are done by people who are local, known, and trusted. I remember I saw this first in New York, and it was deep, for me, it was deeply inspiring. We had created 5 new sites across the state. And people were wondering, could this really be disseminated, or is it only the national team? And so I'm kind of sitting in the back watching a new team in Buffalo. And so there were 2 primary care docs, 2 lovely physician ladies, pediatricians, and then 2 child psychiatrists. And this one pediatrician was standing there. She was talking about depression. And she began her talk, and the material she was presenting, by saying, I can't believe I'm standing in front of you. I was sitting where you were sitting last year. And then now she's begun the teaching. She's not a child psychiatrist, but she's an expert pediatrician who knows what she can do in primary care. So she finishes the material she was presenting. Then there was a panel, and the 2 pediatricians and the 2 child psychiatrists were up there. Guess who got all the questions? The pediatricians. Because the audience was saying, how did you do this? How did you do this? Didn't your patient say this or that? Wasn't there resistance? And that's when you see these 4 9s and 5s, those are usually our local teams now that have been brought up to speed. But we've also learned what it takes to do a good training. And so when anything dropped below 4.5, we say, that team's got to go back to the mill. They've got issues. And so in this case, here we could point to 2 trainings, and we said, these trainings, no, this is on a scale of 1 to 5, so you can say 4.4 is between excellent and above average. No, we've learned you were not at least a 4 or 5. Actually, there was some failure of the team to really pull it all together. And that has to be addressed if we're going to keep the effectiveness of the program. So now what do we know about the program? Well, again, we've had several grants to study it. And we've seen from a variety of studies that it is clearly linked to behavior change. If you go and look at doctors' charts, they do different things before and after training. We've also seen that it saves money. You look at it, Medicaid data, trained versus untrained doctors. And surprisingly, they use fewer medicines. Isn't that cool? More likely to intervene, be comfortable intervening with the family, but not pull out the prescribing pad for pretty much every problem they see. Better family adherence. So where we want to go with the Reach Institute is kind of bring all these forces together. We've got to have a trained workforce. We've got to have systems that support those docs within those systems. We've got to embed a lot of that in primary care because that's how we're going to increase access and how we're going to be effective in our prevention efforts over time. I'm looking forward later on, perhaps in the afternoon, to talk about how we might even do that here in Louisville or Kentucky. We've got partnerships now with multiple states. Arkansas, New York, we've been in Minnesota, North Carolina, Idaho, Colorado, and now various large healthcare organizations, Geisinger, etc., Beacon Health, and others. So it's a new area. You might have come in thinking, okay, I don't do dental and I don't do mental, but let's see what he's got to say. But I would like you just to think about the difference a great primary care provider can make in a child's life if you embrace this area, overcome maybe any concerns, and say, I've got to master this. I've got to learn. In many ways, it's a leap of faith, but it's a leap to save a lot of the children who otherwise, without your assistance and care, would not receive the help they need. Thank you very much.
Thank you very much for an excellent presentation. I'll open it up for a couple of questions for Dr. Jensen.
Don't be shy.
Hi. So I'm an allergist, immunologist by trade, and obviously I certainly see a fair amount of mental health in my practice as well. You know, obviously I do seem motivated by your talk, and obviously, with you have a wonderful program there, but I was just wondering if you recommend any other resources. I do know there's an ADHD practice improvement module available by the ABP, but in terms of other mental health disorders, is there Part 4 MOC type activities where I can get feedback about my performance to motivate better improvement in my practice?
Great question. Actually, we're working with the ABP right now in developing 3 or 4 new modules. So I was a part of the group that helped develop the ADHD module and a depression module. Problem is there's a lot of different skills. And so, for example, in the ADHD module, how do we really refocus it so it's on optimizing the medication management? Or in depression, not just screening for depression, but think of all those other skills. How about general screening for mental health issues? So those are modules that are really haven't been developed. How about aggression? There's a lot of work, and so we hadn't done MOC up till recently, but we're now in the midst of applying for where if you took the REACH training program, you could also fulfill your MOC credit at the same time. So that's very much a goal. By the way, I should just remind you, I take no money from REACH. All my time is donated. It's a nonprofit, and so there's no formal conflict of interest by any financial ties whatsoever. It was created to be a nonprofit to serve children's health needs.
Thank you. Any other questions?
Hey, Alan.
Real quick one. You know what I'm going to ask?
Uh-oh.
So if you look at the action signs, the ACEs, and indeed my comment about bipolar disorder being diagnosed because children are angry when they don't get their way, these are all, the family is the core issue. It all comes back to, if you look at the action signs, they're all related to and ACEs. So in the training, and the pediatrician has 15 minutes for a patient kind of thing, what have you learned about how they connect with the parents and the teaching regarding that?
That's such a key skill. Now we actually embed into how do you interview? How do you capture a parent's heart? How do you bring them on board so they're partnering? How do you empower them? And so, just to follow your point, which I think is exactly right, let's assume you've got a kid with depression. Well, it's likely there's going to be 2 or 3 ACEs there. And if you just treat the depression, you're missing half the boat. And so that kid is still going to be in a high-risk environment. So how do you work with the family? So those skills, so we teach how to engage, how to interview, how to bring the parent on board, but we don't teach things like family therapy. I would say at that point, you have to capture that family and take them by the hand and say, I need you to see this therapist. He's got to work with you. So we teach them how to address the family issues and then get the family into the care they need. It won't happen overnight, but to say, I've got to. But they're afraid to address the family issues, and so they have to get that first skill. And so that's what we're seeing. But it doesn't totally close the gap because sometimes it takes a year or 2 to convince a family to do what they need to do. We give the one model. If a parent said, I'm too busy to have my child's leukemia treated. I have to treat 80 miles. I know he's got leukemia, but I'm just so busy. Well, what primary care providers say, oh, dang it, they won't follow my referral? No, you would say, you got to. And you don't leave any stone unturned to make sure you've done everything to engage and motivate and get them to where they need to be. Same thing's true for mental health. These are like cases of cancer.
Okay, any other questions? Yes.
For your pediatricians doing REACH, do you ever screen them for ACEs?
Say it one more time.
Do you screen your pediatric attendees for ACEs themselves? What do you bring to the job?
Oh, it's a good question. No, we don't do that. But one of the things I do love about working with primary care docs, like I said earlier, they make amazing teachers because their hearts are in the right place, and then they can become such wonderful role models. And I see so often where someone says, I want to give back. I love doing what I'm doing in my practice, but I want to give back even more. And that's, if you think about teachers who changed your life, that's kind of partly what begins happening. Someone changes their practice, and then they're helping kids they never could have helped before. They're deeply inspired, and they want to be able to help other docs do that too.
Okay, very good. Thank you so much.